Hello, friends, and welcome to the Diabetes Pro Tip series from the Juicebox Podcast. These episodes have been remastered for better sound quality by Rob at Wrong Way Recording. When you need it done right, you choose Wrong Way. WrongWayRecording.com. Initially imagined by me as a 10-part series, the Diabetes Pro Tip series has grown to 26 episodes. These episodes now exist in your audio player between episode 1000 and episode 1025. They are also available online at diabetesprotip.com and juiceboxpodcast.com. This series features myself and Jennifer Smith. Jenny is a CDE and a Type 1 for over 35 years. This series was my attempt to bring together the management ideas found within the podcast in a way that would make it digestible and revisitable. It has been so incredibly popular that these 26 episodes are responsible for well over 500,000 downloads within the Juicebox Podcast. While you're listening, please remember that nothing you hear on the Juicebox Podcast should be considered advice, medical or otherwise. Always consult a physician before making any changes to your healthcare plan or becoming bold with insulin. This episode of the Juicebox Podcast is sponsored by Ascensia Diabetes, makers of the Contour Next Gen blood glucose meter. And they have an amazing offer for you. Right now, at my link only, contournext.com/juicebox free meter, you can get an absolutely free Contour Next Gen starter kit. That's contournext.com/juicebox free meter. While supplies last, U.S. residents only. The Remastered Diabetes Pro Tip series from the Juicebox Podcast is sponsored by Touched by Type 1. See all of the good work they're doing for people living with Type 1 diabetes at touchedbytype1.org and on their Instagram and Facebook pages. This show is sponsored today by the Glucagon that my daughter carries, Gvoke HypoPen. Find out more at gvokeglucagon.com/juicebox. Jenny, let's do a big sick day episode. And so I'd like to try, if we can, to get through sort of a regular sick day, like, a little beyond the sniffles, the flu, a stomach virus, an injury like a broken bone or something I might have to take, a steroid for, and then an actual surgery. And where do I want to start? You've had a surgery pretty recently, haven't you?
I've had multiple surgeries. I've had awake surgeries. I've been out surgeries. I don't like surgeries, but I've had them. Yes.
So let's start there. A, because you got good information about it, and B, because Arden is going to have a cyst removed in a couple of weeks. So I'd like to hear about this. So let's start with something you were awake for. I guess also like dental procedures would probably fall in this category a little bit, maybe not.
They would be a little bit different only because like a dental surgery, if you're going to be awake for it, like just a tooth removal or something like that, usually the awake component to it means that you don't really have to go in fasting or without any food in your system, those kinds of things. If it were going to be, I know now they usually try to take all the wisdom teeth at once if they're going to do that. And oftentimes now I've heard a lot more people being completely put under.
My son was.
For wisdom tooth, extraction. I didn't. My dentist said, your mouth is not big enough. You need to have your teeth come out, but there's nothing wrong with them. As they come in, we're going to take them out. So as my teeth kind of came out, and honestly, my wisdom teeth didn't completely come through until I was well into my 20s. Mm-hmm. And so they just took them out in office.
So I'm going to make a note here to myself because it has nothing to do with this, but my wisdom teeth extraction story is absolutely insane, and I will tell it at the end. So I literally just made a note to myself. So if I'm just going to the dentist to have a cavity done or something like that, not a lot for me to do, probably handle things the way I normally do.
Correct.
I guess
one big thing to make sure is, especially if you're new to having it done, is, and you've never had any like pain medication, You may experience a little bit of a higher blood sugar, potentially a stress component from having like the Novocaine. I mean, that needle it's scary.
Yeah.
It's a scary looking needle that they're shoving in your mouth, right? And it doesn't feel very nice either as they inject it several times. So for those of those people who've never had this done, it's not very fun. And if you ever do have to have it done, it's not a fun thing. But it could cause a rise in blood sugar because of a pain component, because you're just in a setting that's completely not under your control. So, but other than that, yeah, you shouldn't have to go there fasting or make any true adjustments to anything. In the future, if you had a second surgery or a tooth extraction or tooth work and you knew what happened the first time, you could potentially look back and maybe make adjustments like setting a temp basal increase or taking a small amount of bolus ahead of time to offset a rise if you don't want it, or just correct after if you're not quite sure what's going to happen.
Yeah, especially I'm thinking if you're trying to, I'm not usually up for like run high to avoid a low kind of situation, but if it's an hour and a half in the dentist office and it makes you comfortable, let your blood sugar be a little higher for that, and then get at it. And because I guess too, if you're numb, taking in juice or gel or something like that could end up, so you don't want to be in that situation.
Could be harder. Yeah. Exactly. Yeah. So in some things like that, it's a little bit safer to potentially be a little higher if it does end up rising. I mean, obviously don't go in at a blood sugar of 250 just because you're scared. But if it rises up, higher than you'd love it to be, again, an hour and a half of being too high, you can correct it after without worrying that things are going to drop too much and you can't chew anything, then that's okay.
So this is so funny. I'm going to ask you, when I say leave it a little higher, I have a number in my head. What's your number?
I'd say a little higher would be like 180-ish.
Oh, yeah. So I might be insane, actually. So I was like, it could comfortably be around 135-ish in there. You don't want to get crazy. That thing starts drifting to 160. I got to fight with it then, Yeah. But the point is wherever you feel like you can keep the control. And if you're real stable, that could just mean like dialing your basal back a little bit to just let your blood sugar kind of come up a little bit.
Correct.
You might not have to eat something to make it happen. Okay. So that's simple. Now, moving on to the next step of it, wisdom teeth knocked out cold. Now, I do know this from my son. If you get a good doctor, you're only under a very short time. But when you come back, you are not in any shape to make decisions, drink, eat. My kid said some crazy stuff on the way home from that doctor. And then even once his head cleared out, which I have to admit didn't take too long, he's bleeding. His mouth is packed with gauze and everything. So I guess are we in that situation now? We're better high than low?
It would be better than to be, and again, in that case, if you went into that surgery to be put out and your blood sugar was nice and stable, let's say 120 even, it should, for the short amount of time of that type of a procedure, it should remain stable, or it might climb again from the stress on the body. Yeah. In the aftermath of that, though, again, it would definitely be better to be a little bit higher than you're typically running. And again, I'm not saying like 180, 200 high. Obviously, you could correct to bring that down safely. But if you're running like 140, leave it. Yeah. There is no detriment there whatsoever at 140, until you can take something in or start to eat, or whatever the dentist told you for when you could start to eat again. Even with my wisdom teeth being taken out one at a time, I think I had 2 taken out the first time. It was a bottom and it was a top wisdom tooth. And I remember a couple of days of like just soft. It was, where the chewing component just was not pleasant. So having a plan of action too, just like on any other sick day kind of thing, having some things ready to go, especially if you're an adult and you're taking care of yourself, having some soup or some broth or some Jell-O or yogurt or popsicles or even ice cream or whatever it is that you can tolerate, soft enough, don't have to chew it, that you can get something in.
I think that as I'm thinking about this happening for Arden next year, probably, my plan would likely be higher, not so high that it could get away from you higher, but
right.
controllable. And then if it tries to move, just kind of keep tamping it back down a little bit, like so that you're in the power position, right? It's not out of control high so that you're going, oh geez, I have to use a lot of insulin here. And it's not low. Just, you know what? It tries to come up, push it back down. Like play that game for a little bit. So you've got the level you're looking for, but you're still reasonably in control of what's happening. Put yourself in a power position there. I think that's how I'm going to handle it.
That's correct, considering the fact that, as we've said before, the littler incremental adjustments sooner mean less insulin sitting there to potentially dump you down too low later.
Yeah.
And in a setting where you can't actually take anything in, whether it's a mouth surgery or this might even move into kind of like stomach bugs or those kinds of things where you may not be able to take anything in or not quite sure when you can take anything in, it's certainly better to nudge little by little rather than take this big whopping adjustment and then you can't eat anything to offset it.
Yeah. I think bumping and nudging is the way to go on this. So as I'm considering it right now for the first time talking to you, and when Arden's wisdom teeth come up, I think that's definitely what I'm going to do. I'm going to shoot for 140 in that range, take your advice over my advice, maybe more like 140, 150, and then just keep knocking it down if it tries to run away, basically. Just kind of keep tripping it as it tries to get up and run. Like, nope.
And find out ahead of time what her favorite soft or cold things are so you can have them ready.
Well, yeah, you're going to have to prepare, right? Like you're going to have, this is not something you're going to want to think about after the surgery is over. You're going to want this stuff in
Let
the
her
house.
sit in the parking lot of the grocery store where you run in and be like, what did you want to get? And her mouth is full of gauze and she's like, I don't know.
Yeah.
Right?
I can't get her to pick food when she's not sick or injured. Like we were at the grocery store yesterday. I'm like, can you just grab a couple snacks for lunch, whatever you're looking for? I don't know. You decide. And I said, how about those? She goes, no. And I went, well, how are you going to tell me decide? And then I say something and you tell me no. I was like, what if I grab something that she goes, if you show it to me, I'm going to say no. If you bring it home, I'll eat it. And I went, oh, well, that's a reasonable understanding of your psyche. I was like, okay, great. So I did. Anesthesia impact at all?
So some people, myself being one of them, not only do I have experience with surgery, I have experience with anesthesia. My body doesn't like it. Okay. So again, if you're going into something where you've never had any anesthesia whatsoever before, just be aware that it can cause some like post-operative nausea. Many people get a little bit like woozy headed. I myself just don't tolerate it at all. I talk to the anesthesiologist ahead of time. I say, you need to load me up with whatever tools you have because I will probably throw up on the nurses when you get me awake. And there's only literally been one time that I had a hernia surgery, an umbilical hernia. And man, if I could carry that anesthesiologist around in my pocket, if I ever needed surgery again, and his little toolkit of medications he used post-surgery, I was golden.
Right.
I didn't feel horrible. I mean, normal, but not like nauseous, whatever. So anesthesia can cause some nausea, so just be aware of that. If you know that's an issue, again, talk to the doctor about it ahead of time. There are many different kinds of medications they can use to stop that.
Okay.
And it depends, on post-surgery. Sometimes they'll try to get you to nibble or drink a little bit of something in the post-op when you're, recovering, waking up. You can also be really, really woozy, like in and out of like waking up and then getting really drowsy again. And that it takes for everybody, it takes a little bit of time to wear off. Usually in a post-op setting, they'll probably have you in recovery for at least an hour. It could be longer than that, depending on how you seem to be doing. So I've always brought somebody along who knows how to look at my pump, how to potentially do a finger stick for me, even though the nurses there could definitely do that for you. So my mom has come to a couple of my surgeries. My husband was there, obviously, for both C-sections that I had. So it's really, really, really advantageous if you've got a go-to person to be there after. It's
so funny. I alluded to this while we were recording recently, but I have a question. It's on the tip of my tongue. And if you would have paused, I would have asked what you said. I'm like, one of us doesn't need to be here. I'm afraid it's me. No. So I was going to say, did you wear your pump? And,
yes.
How did you take control of it? What did you do? So as long as you were coherent, you were doing it.
Correct. As long as I was coherent, I was doing it. It's also really an ahead of time for any type of surgery. I mean, again, like a dental kind of thing, a dentist could probably really care less as long as things are okay and controlled when you come in. They may, if they know you have diabetes, they're definitely going to ask when you come in, are your sugars okay? Are they controlled? Are you feeling well? Whatever. They're not going to know anything about telling you to do or dial back or dial up or anything. No. That's a dentist. Typical doctors, though,
will be more involved.
And they... it's really important thing to talk ahead of time.
Right, because they're, as a default, going to just err on the side of, I'd rather see your blood sugar be 300 for the next couple of hours. They're always going to feel that way. They don't really want to be managing your blood sugar.
They don't.
Yeah. I've seen this now in multiple people in my life, type 2, type 1, all the way down to my friend Mike, who was in a coma at the end of his life. And nobody gosh, I don't want to say they didn't care, but it was a problem they weren't prioritizing, I guess.
Correct. It was a secondary issue.
Yeah. They think of it that way.
Yeah. And they're concerned. I mean, from the medical standpoint, in fact, if you don't address the fact of staying on your pump and keeping your CGM on and whatnot, as long as you can keep them on, there are some medical procedures that include machines in the operating room that could potentially require you to be off of your products just from a machine, I guess, interference standpoint. So there may definitely be some things. There may also be length time of a procedure or a surgical procedure that determines you need to be on an insulin drip versus being left on your pump. So, those kinds of things, there is a definite difference. But for shorter lived surgeries, if you go in with your team and you talk to them and you say, hey, you know that I'm on an insulin pump. If you've got backing of your endo, you can have your endo write a letter of approval for you to remain on your pump and your continuous monitor through the surgical procedure. Your doctor may even include in it, glucose levels. We've discussed she or he will come in with a glucose level here to here. She or he will have a temporary basal adjustment set. Many doctors are a lot more conservative than you need to be for surgery. Many doctors will say dial the basal back by 50%.
Just way too much. Yeah, that seems like a lot.
Again, which is a lot. And for most people, again, there are the rare people who have a drop in blood sugar from that stress impact and whatnot, but it's not common. It's more common for stress to cause a rise in blood sugar. Okay. So, dialing basal back kind of goes back to some of our other episodes about like testing things. If you're going into a surgery, first thing, they will usually have somebody with diabetes on insulin have surgery first thing in the morning. They will not push it into the later afternoon or the evening, mainly because they'll want you to come in a fasting state. Yeah. And it's easiest to get that in the morning for somebody with diabetes. Therein lies, do you know that your basals are doing what they're supposed to do? Yeah. If you've got time, test them. Can
you imagine, too, you're going to need to be fasting for a procedure at 8 a.m., and you wake up and your blood sugar's 45. What are you going to do? Right. You're going to have to do something. And now you're going to have to show up at the hospital and say, I drank juice this morning. And then they're going to boot you back out again. And you're going to have to reschedule. So, all right, that makes sense too.
Yes.
So conversations ahead of time with doctors. I'd like to control my own insulin pump. I can do it when when I'm not capable. I've got a person here to help me. Here's a letter from my endocrinologist outlining, some of my goals for my blood sugars, that they'd like me to be able to stay on my devices. If I'm MDI, I don't want to be on on an insulin drip. I want to inject my slow acting, the way I always do. And probably having a little bit of, I don't know if charting's the word, or records to be able to show the doctor, like, look, here's what I do. Normally, I feel confident I can come in and accomplish this.
Correct.
Yeah, it's probably important.
Because it eases their ability to also chart and say, this is the plan of action. This is where, this patient's glucose levels, they're controlled. The insulin doses are here. The glucose levels are usually here. This is where they came in the morning of the surgery, even showing them. Every surgery I've gone into, all the nurses have been fascinated with the continuous monitor. They've been fascinated with it.
That happened to Arden when she went into the emergency room for that belly pain. And you and I talked that day, actually.
Yeah.
And the nurse who was way in charge, super confident and competent. And when she saw that thing, she's like, this is amazing. And I was like, yeah, right. And she's like, all right, well, what do you want to do? And I was like, it was that moment when I said, listen, I'm not trying to be like, I'm not blowing a horn here or anything like that. I'm like, but my daughter's A1C is incredibly stable on the lower side, her blood sugars. And I showed her, I'm like, this is her blood sugar for the last 24 hours. I'm like, I'm completely confident that I can keep her blood sugar here. And if I can't, could we just do, like, she's got an IV in, right? You could hit her with, with glucose that way. Dextrose, right. Mm-hmm. And so that actually happened. We were there for so long that they did have to run dextrose. And it was really interesting to watch because it took forever to hit. And then it jacked her up. But if you gave her any insulin at all, it went right away in 2 seconds. It's very, very interesting to watch how it worked. But when going into that scenario, right away, after we were settled, like, I didn't run in the door yelling, she has type 1 diabetes and we're going to take care of it. Like, after we were settled, we were there for a little while. I'm like, hey, listen, here's the situation. We'd love to stay like this. And then, to be honest, she seemed thrilled to let us do it. Mm-hmm. It almost felt like, well, then I won't have to do this. So perfect. It was a little bit of that. And okay. Right.
That's actually, for the most part, what I've experienced. There's almost like you can't physically see it, but you can see it because with diabetes, we become very intuitive to other people's, like, what you can see them thinking. You can, like, hear their gears going, right? And every time I've come in for a surgery, I can almost, like, see the nurse, like, go, it's a relief. Like, their shoulders, like, relieved. They're like, somebody has control of this and we don't have to worry about it. They will ask where your glucose is. Mm-hmm. If you do a finger stick or look at your CGM, report it to them, make sure that they know and are aware of where things are going. If you did it all, make an adjustment to your insulin doses or take anything, make sure to note it to them so that they can chart it, because it becomes part of the medical record then. But yeah, my first child, when he was born, we knew it was going to be a C-section. And so we came in, planned everything. And the nurse anesthetist who was there during the C-section, she actually, at that point in time, I had the receiver yet for my Dexcom, right? I was still using it. And she was holding it because my husband was, like, with me, obviously. And she was amazed by it. She's like, it changed again. She's like, now it's 81. And I'm like, yeah, it'll give you a new number every 5 minutes, right? Yeah. But she was so just enjoying watching. She's like, this is a really steady line. And I was like, yeah, that's what happens when your insulin is dialed in the right way. So,
to your point, I'm recalling a conversation I had with a nurse in a hospital setting. And we talked about this. And she told me that one of the things she dreads the most is running up on somebody who really, doesn't have a firm idea of what they're doing. And she's like, but they feel like it's working for them.
Yes.
And then you feel like you're in now the position of explaining to them, like, oh, this isn't okay. This should be more like this or more like that. And she's like, and that's not my job. And, and they don't take it well. And they're already under stress over a lot of other things. And now here you are in the corner of the room going, oh, by the way, you don't do a very good job of taking care of your diabetes. Here's what you should be doing. She's like, it's not the right time.
No, it's not at all. In fact, when we went in for my second son's birth, management had already been established, endocrine and my MFM team had already written, Jenny will manage. If she's unable, her husband is here. He can help her manage. She will remain on her pump, et cetera, et cetera. And the nurses were really, really surprised by that because they had a woman the week prior come in on a pump and they thought she knew, just like, everything I was saying.
She
they
said
thought
she did, probably, yeah.
they said, okay, we need you to dial back, your rates by this much, blah, 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 because she didn't come in with a plan of action herself. And this woman, unfortunately, literally didn't even know how to button push on her pump.
Right.
So I don't know the whole story other than the fact that the nurses and the doctors were like, well, you can't safely, we cannot allow you to stay on your pump. Yeah. And so she was so excited. She's like, I'm so glad you know what you're doing. She's like, this was the scenario we had.
I hopefully this will give the confidence to other people to make these kind of like pre-planning decisions too.
Right.
Okay. So let's, injury. And I only have one example, but Arden got hit really hard in the kneecap with a batted softball once. And her blood sugar began to rise almost immediately after the pain hit her and stayed up for the better part of 18 or 24 hours. She needed a lot more insulin. Now, I don't think there's a lot to say to this other than there was an impact coming from her body that required more insulin, and I gave her more insulin. But is that a hard and fast rule that pain puts your blood sugar up and constant pain can hold it up, or that's person to person, I would imagine too?
For the most part, yes. I mean, as kind of just a blanket statement, yeah. If you're in pain and it's considerable pain, blood sugars will be higher. If the pain ebbs and flows, you may find a little bit of kind of a drop down as things feel much better. And if it starts up again, maybe between pain medication or whatnot, it may start to escalate again. So yes, pain's a horrible thing. Yeah. That's actually one of the things that I, in having had 2 births, the management of pain post-delivery was most women's insulin needs fall dramatically after they deliver child and placenta and everything, and all those pregnancy hormones are gone. Right. But after a surgical delivery, like a C-section or a more traumatic delivery potentially, you may actually see that the stress of that and the pain that you're in could leave those glucose levels higher, requiring more insulin, despite the pregnancy hormones being gone. So that's kind of a similar example.
You're swapping the hormones for the pain, right?
Right.
And I did see with Arden's knee that when pain, and she was only taking Advil, but when it worked for her, she needed less insulin. And then at the end of that Advil, if I didn't overlap it correctly, then she'd start to go up again. Okay. Well, I just wanted to hit that. But now we're gonna jump into the illnesses,
Yeah. Can I make a comment on one thing?
Of course.
Prior to illnesses, since we've been talking about like planning for surgery and all of those kinds of things, if you do have a plan of action and you'll be going into the hospital, the other things to definitively know is your length of stay for that. Okay. Because you do have to plan ahead for how much may you need to bring along as far as supplies, right? Especially if you're on a pump, if you're on a CGM, you want to make sure that you have enough that you don't have to either send somebody home. The hospital will not have anything to help you out with your pump supplies.
Yeah. They're not going to offer you an Omnipod if you need
one. They're not going to. They, certainly they've got glucometers in the hospital. They've obviously got insulin. If you're really stuck on your type of rapid acting insulin, for another example, and you've got something planned coming up, make sure to bring your insulin to the hospital with you. You may have to give it to the nursing staff. They may have to hold it in the medical area with your name and label on it. But otherwise, you're kind of going to be at liberty of whatever's on formulary at the hospital. And it could be the kind of rapid insulin either you've never used or maybe it just doesn't work as well for you.
Have you ever had an experience yourself or spoken with somebody who's had the experience where they go into the hospital wants to leave their blood sugar higher, the people say, I don't want that, but the hospital resists, and then the person sort of Mission Impossible style gets insulin to themselves? Because I've heard that from a lot of people. Like, I had to hide my pen from the nurse, like that kind of stuff.
Correct.
Now that all seems.
In fact, I'm sure she wouldn't mind me answering it because Ginger, who I wrote my book on type 1 with, she is an MDI. She takes multiple daily injections. She doesn't use an insulin pump. And her first delivery, that's what she had to do because the nurses were like, we don't want you. I don't know. They told her to take her insulin dose down or up by so much that Ginger was like, that's going to kill me. She's like, you can't do that. And
Right.
so, yeah, she had her like insulin pens in her room with her. And when the nurses weren't in the room, she just dosed herself. Now, am I advocating for that as a healthcare professional? No, I'm advocating that you talk to somebody. But you know what? If in the case of the question that you ask, if they're just leaving it like so much higher, detrimentally higher than would be healthy for healing, I would advocate for bringing in like a patient advocate, asking the hospital to bring somebody into the room to talk with, because there has to be a safe workaround that you're being safe and the hospital staff knows what you're doing, but that you're doing what you know is better for you.
You know how this always happens, because it happens in so many different walks of life in and around diabetes and separate of it too, especially at school, by the way, with like how people take care of their children at school. There's this idea institutionally, this is how we do it. And when you come in and say, hey, that's really cool, I'm glad that works for people, I would like to do it like this. I go, no, this is how we do it. But no one remembers why this is how we do it, right? Like, and it really is, it's the meatloaf story. You know, it's. Have I ever told you the meatloaf story? I've said it on the podcast. So. It fits here. I'll do an abridged version of it. Mother and a young girl. It's a pot roast, actually. Mother and a young girl are making a pot roast. Mother gets out the pan, cuts the ends off the pot roast, puts it in the pan, sticks it in the oven. The daughter says, "Why did you cut the ends off the pot roast?" Mom thinks for a second and says, "I'm not really sure. That's how my mom made pot roast." So they find the grandmother, ask her. Grandmother says, "I don't know. You're going to have to, next time you're at the old age home, find my mom and ask her why." So they visit the old age home and they find the mom. She's 100 years old and all curled up in a ball. "Grandmom, do you remember why we cut the ends off the pot roasts, when we make them?" And the old lady thinks and she goes, "Oh yeah, I had a really short pan."
Right.
Yeah.
That's what I was thinking.
Exactly. So you don't know why the hospital's saying what they're saying. You don't know why the school's saying what they're saying. And sometimes you just have to be reasonable, like you said, and talk and say, "I get this is what you normally do, but hey, this is what we do, and look how well it works. Couldn't we find a middle ground here?"
Correct.
The problem is sometimes that communication breaks down because of, I know on my end, when it would break down for me in the past, it's always emotion. Like, you're very emotional and you feel like, oh, you're going to ruin my kid's life or something like that. Or, you're going to hurt somebody, and you feel, and then you start wrong. And then before you know it, you're arguing. And so you have to you got to come at it from a real calm place. But that's, I'm not advocating anybody doing that either. I'm just saying that the number of people I know who have done that is more than I can count on my fingers.
Well, and something that kind of goes along with that too would be sort of an emergent type of setting where you come to the hospital unplanned, like an emergency room, right? A really important thing is that if you're awake with it or somebody who's with you can advocate for you, it's not odd for them to want to disconnect a pump.
Right.
Do not let them disconnect your pump. If I had to say that like more forcefully or whatnot, if you are with it enough, do not let them take your pump, right? Because they don't know. Emergency department personnel, they're great clinicians, but they see a host of things,
right?
Trauma, problems, issues, whatnot. They are not schooled in insulin pump management. They're not. So that's a really, really important one.
And these are emergencies that aren't the top end of the emergency. Like if you're really injured, you know what? These people are going to try to keep you alive. You stop thinking about your insulin pump now, but like that kind of stuff.
Right.
But yeah, in moments where you're cognizant, it's a weird thing. Like, why would you give over the control of your insulin pump to somebody just because you broke your toe and you're in the emergency room now?
Correct.
That doesn't make any sense.
Exactly.
Okay.
That's also the benefit of having a
medical alert
ID.
Bracelet. Oh, look at Jenny is wearing her bracelet. Don't you?
Oh, it's always on. I think actually I glued it closed because I've lost it. It comes from American Medical ID, by the way. They do a great job, but my clasp had come, like it unsnapped twice already, and I've had to reorder the same bracelet. So now it's glued closed. Like they would literally have to cut it off of me to get it off.
I was going to joke that Jenny is making side money mentioning American medical bracelets on the podcast. And then she said it broke twice. And I thought, well, that's probably not what they want people to hear. So.
And it was the clasp, and I'm quite sure that it was, my fault of catching it, whatever.
It's just
but, yeah, it's, so actually it's funny because when I went into the hospital, the last time for my kidney stone, which was not fun, it was a whole bunch of extra visits and whatnot after. But I told them, I was like, they wanted like all jewelry and like everything removed. And I was like, well, you're going to have to cut it off then because it's glued together. And the doctor was like, okay, well, we'll just put some, whatever it's called, like Coban or K-ban or whatever around it. And he's like, you're fine.
It'll be fine. Oh, there you go. There's Jenny's had diabetes for over 30 years and she's wearing her bracelet. Now, don't you all feel bad for not wearing yours? I don't even think Arden has one, so I'm feeling particularly bad in the moment. Okay. I'm so sorry. You know what? It's funny. It's when she gets older. Like, then I think of it. Like, right now, she's with somebody constantly who knows she has diabetes. It's, but it's those other moments. I guess it's the ones you can't plan for,
I've got a lot of friends who've gotten tattoos, actually, type 1 wrist tattoos. I've actually got a good friend in Michigan who she even talked to some EMTs and she asked specifically about her design so that she could know from a medical perspective, would this be visible enough? Would this be recognized as a medical ID and whatnot? So there are some beautiful designs that are out there. I just have never gone that route.
One day.
I have a tattoo, but I just don't have a tattoo on my wrist.
Are we sharing where your tattoo is or no?
It's on my leg.
Okay. Well, I have a couple of tattoos.
Yeah.
I have one at the top of the crack of my, no, I'm just kidding. It's on my shoulder and one on my shoulder and one on my leg.
Cool.
Mine aren't that cool though. Maybe they are. I don't know. I've had them for so long that sometimes I look in the mirror and I see it and it startles me. The one on my shoulder happens sometimes. Sometimes like, what is on me? And then I realize that 25 years ago I got a tattoo and I don't see it because it's behind me. Anyway, okay. So let's start with the easiest version of a sick day, right? Like a cold, sniffles, a cough, like something that doesn't, morph into something worse. Just something that is you're under the weather. How does that always present with your blood sugar the same way? Like for you personally? The Remastered Diabetes Pro Tip series is sponsored by Ascensia Diabetes, makers of the Contour Next Gen Blood Glucose Meter, and they have a unique offer just for listeners of the Juicebox Podcast. If you're new to Contour, you can get a free Contour Next Gen starter kit by visiting this special link, contournext.com/juicebox free meter. When you use my link, you're going to get the same accurate meter that my daughter carries. contournext.com/juicebox free meter. Head there right now and get yourself the starter kit. This free kit includes the Contour Next Gen meter, 10 test strips, 10 lancets, a lancing device, control solution, and a carry case. But most importantly, it includes an incredibly accurate and easy to use blood glucose meter. This Contour meter has a bright light for nighttime viewing, an easy to read screen. It fits well in your hand and features second chance sampling, which can help you to avoid wasting strips. Every one of you has a blood glucose meter. You deserve an accurate one. contournext.com/juicebox free meter to get your absolutely free Contour Next Gen starter kit sent right to your door. When it's time to get more strips, you can use my link and save time and money buying your Contour Next products from the convenience of your home. It's completely possible that you will pay less out of pocket in cash for your Contour strips than you're paying now through your insurance. contournext.com/juicebox free meter. Go get yourself a free starter kit. While supplies last, U.S. residents only. Touched by Type 1 has a wide array of resources and programs for people living with Type 1 diabetes. When you visit touchedbytype1.org, go up to the top of the page where it says Programs. There you're going to see all of the terrific things that Touched by Type 1 is doing. And I mean, it's a lot. Type 1 at school, the D-Box program, Golfing for Diabetes, Dancing for Diabetes, which is a terrific program. You just click on that to check that out. Bowl for a Cause, their awareness campaigns, and the annual conference that I've spoken at a number of years in a row. It's just amazing, just like Touched by Type 1. touchedbytype1.org, or find them on Facebook and Instagram. Links in the show notes. Links at juiceboxpodcast.com to Touched by Type 1 and the other great sponsors that are supporting the remastering of the Diabetes Pro Tip series. touchedbytype1.org. When you have diabetes and use insulin, low blood sugar can happen when you don't expect it. Gvoke HypoPen is a ready-to-use glucagon option that can treat very low blood sugar in adults and kids with diabetes ages 2 and above. Find out more. Go to gvokeglucagon.com/juicebox. Gvoke shouldn't be used in patients with pheochromocytoma or insulinoma. Visit gvokeglucagon.com/risk.
For me personally, it does. I've found that just the typical sniffles, I'm not really feeling bad. I'm just feeling kind of like stuffed up or something. Typically, I don't see any change in my blood sugars whatsoever. I don't see any change in my insulin needs whatsoever. It's not really until I start feeling sick where I might feel a little more fatigued, tired, kind of run down, like I could go to bed like at 8 p.m. instead of 10:30,
right,
kind of thing. Like a good thing for me to know that I really don't feel good is that I just don't want to work out, because I typically do something every single day for a workout. And if I really would rather like skip the gym,
you feel like that's
I know that I'm really not feeling great. But blood sugar wise, I already know that I'm not doing great because I'll see an incremental creep. Excuse me. I usually need about 20-25% more insulin with something that's got me kind of just not feeling the best at all.
Right. So with Arden, when she has the regular just sick day sickness, her blood sugars are so easy to control those days. I don't like, but not like I'm coughing and my chest hurts or there's, snot flying out of my nose or something like that. Just when she's a little under the weather, her blood sugar is easier. Now, maybe if I really delve into that, maybe she doesn't eat as much during those days. Like there could be another reason that I'm wrong about. But I have heard people say, both ways, like I need more, I need less. And so for this, right, hydration really is got to be step one in probably all of these, right? You have to stay hydrated, keep food in you, as best you can, so you don't get into one of those deficits where you've got a bunch of insulin going and there's nothing inside of you and you drop quickly. It is kind of morphing that from just a regular sick day to a slightly more sick day where you're under the weather, maybe have a bit of a fever. Is the biggest fear, what if I need to eat and I can't? Or what if I get sick to my stomach and my stomach empties? Like, what do you think of the biggest fear around being sick as being?
I would say it's more it's not like the congestion, the nasal, the bronchitis, the ear infection. That's usually not. It's more the bugs that hit the digestive system. Okay. That are the fear for most people. High blood sugars, most people will realize that they need more insulin, whether they're just throwing insulin and correcting because they're staying high, or they actually intuitively are like, I need to bump my basal up. I'll use a temp basal here because I'm just running across the board high.
Right.
That's not so much the worry. It's more the, gosh, I really don't feel very good. Things could be coming out one or both ends and nothing really seems to be sitting well, or you have consistent enough nausea that you can't really do more than a sip every hour. Yeah. Those are more of the bugs that worry people. So, I mean, there are some kind of hard and fast rules. If your blood sugar is on the lower end, declining or dropping, and you can catch it ahead of being too low. You can, if you're using an insulin pump, set a temp basal decrease about 80% for about 2 hours. Okay. So if you're really nauseous to the point that you can't take anything in to stop that drop off, you can decrease basal enough, again, before you actually are too low, to stop the drop and sort of curve you off until you could get a little bit of something. Usually extreme nausea doesn't last like 9 hours at a pop. It kind of ebbs and flows through a stomach bug. So, at some point you could get in something, even in the case of honey, you can put honey in the gum and sort of just massage it in. You don't even have to swallow it, but some of it does start to get absorbed in, through the mouth.
Right.
So
it's funny. So you just described exactly how I help Arden sleep in really long. So on a Saturday, if she goes to bed late or she's been really exhausted all week or something like that, this Saturday is going to be one of those. Like, she's got a lot going on this week, and I know she's going to sleep in. There's a moment like in the beginning of the day, the 6 o'clock, 7, 8, 9 o'clock hour, it's like a 50% decrease in her insulin. And that keeps her 80, 90, right? But if she starts power sleeping into that 10 o'clock, 11 o'clock, 12 o'clock, I sometimes have to go down to like an 80% decrease, just because everything in her body that could possibly keep her blood sugar up is gone now. It's really gone. She's been asleep for 12 hours, 10 hours.
Right.
It's really gone. So I've learned that I can't take all the insulin away, because if I do that, she's going to jump up or be really high 2 hours after she wakes up or something like that. So you have to leave some in, but almost not enough for it to impact the moment at all, just for it to kind of help overall. And then from there, it's great. I mean, the idea of the honey in the cheek, something that doesn't make it to your stomach, because the lining of your mouth is really absorbent for things like this. So your cheeks, under your tongue, right?
Yep.
That kind of stuff. So you can get sugar in there without actually swallowing. I'll tell you too, in a panic situation, if you don't have anything, even table sugar, you can dissolve sort of in the saliva of your mouth and leave it there. There's a lot of ways, but you're going to have to get creative unless you're planned ahead, right? And you have sports drinks that you can take these kind of micro sips off of throughout the day, but all we're talking about here is maintaining that balance with the extra variable of your stomach maybe being sour or incapable of holding the food, right?
And it comes to also prepping, similar to other illnesses and whatnot, kind of, like the discussion about mouth surgery, just prepping and making sure you've got some things on the shelf in your house. Kind of, if it's popsicles that you always keep in the back of the freezer that have a sticker on that say don't touch unless, sick day stash or whatever it is. There's actually a really good electrolyte. It's not pre-mixed. It comes in like one of those little not tubes, but like packets, kind of like Crystal Light almost. It's called Drip Drop. That one works really nice. I think each packet, if you consume the whole thing, it's only about like 9 or 10 grams of carb. But the nice thing is that it's got the electrolyte component to it too, for replacing what might be coming out.
Yeah.
So just some options.
It's very dense with what you need too. And I know about it for a completely different reason. But when Cole was recruiting for college, he got stuck at this 3-day event in August, and it was like 115 degrees. And he was playing baseball for 3 days in a row, trying to, he's like, look at me, someone take me on their damn team, but he was downing Pedialyte throughout the day to stay in that. So it is really impactful.
The other component to stomach bugs and adjustments would be if you are able to take in a little bit, usually because a stomach bug means that you're not absorbing well digestively. We really expect that you're probably absorbing only about 50, maybe 60% of the carb amount that you might be taking in. Don't bolus until you know that it's going to stay down. So in this circumstance, you're not doing pre-bolusing at all. You take the food in, you make sure it's going to sit there, it's going to stay. You bolus only for about 50% of what you actually consume.
This is a survival situation, right?
It's a survival. And again, if you see it coming up, sure, that's where that like little bump nudge kind of with a little bit more, maybe a little bit more, whatnot. But be conservative to begin with, because stomach bugs don't last long. They're not like the common cold, 5 to 7 days, maybe even 10 days. Usually stomach bugs are gone within about a 72-hour time period. You may still have decreased absorption for days after you're feeling better. So don't think it's odd that you might be dropping a little bit low when you're back to eating what you consider normal food after meals. It might just be that your digestion is just not up to par yet. So
if you're a person or a parent of someone who is prone to stomach issues, is having a prescription on hand for Zofran or something like that, is that a good idea? Like something, an anti-nausea medication?
Yep.
I hear people talk about that.
There's another one that's over the counter. It's called Emetrol, Emetrol, I think. It comes in a little white bottle. It's got a rainbow on it. That was something that my second wisdom tooth extraction, the dentist actually recommended for me.
Okay.
For nausea. So, and it seemed to work really well.
So, and if I'm on MDI and I have this illness coming up, how do I cut back my slow acting insulin? Is it a percentage, you think, or where do I start to guess?
It again, in the circumstance that you wake up in the morning throwing up or, just not feeling the greatest and you're taking your basal dose in the morning, you can adjust it. Absolutely. I mean, you could take it back by 10-20% as a starter. If it's really considerable nausea and you're not really sure that you're going to take anything in, you may cut it back even a little bit more than that, and then just cover with boluses of your rapid insulin if you are riding higher through the course of the rest of the day.
Okay.
But don't take an additional dose of your long-acting insulin from what you missed from the initial dose to make up. Don't just wait the next time you need it.
So when you're talking about taking care of kids, I mean, anybody who's a parent who's had a child who's sick, you realize, for sure, like everything in your life stops, right? Work doesn't matter. The television show you really wanted to watch tonight disappears out of your life. The weather doesn't, you're keeping your kid alive. But what if I'm an adult and I'm alone, right? I'm living by myself and I have type 1 diabetes. I'm sick and I'm exhausted and I know I am going to fall asleep and stay asleep. Like, what do I do before I fall asleep? Because that kind of illness, you see people sometimes 10 hours, they're out like a light, right? And it's the kind of illness and the stress on your body. You might not wake up if you have a problem, and you don't want to be in that scenario. You don't even want to wake up with an extremely low blood sugar. Like, imagine having a 40 on top of a stomach virus, right? It's got to be horrible. I'm guessing. So did you ever, I mean, how long you been married? Did you ever live alone? Like, what would you do in that scenario? Would you?
I've personally never lived alone. I went from my parents to having college roommates, to having off-campus college roommates, to then, I think I lived alone for about a month between my college roommates moving out, graduating, and then getting married to my husband.
Your husband should take a lot of comfort in the fact that your face did not go, oh, geez, I do have to get divorced. Isn't that what Scott's saying? No, but I've never lived alone. Jenny has to fly. You looked very comfortable.
But I've traveled alone.
Right.
So in that circumstance too, there are always like safety pieces, when I travel alone, I actually set my CGM alert for a little bit higher over in the overnight time period, just because I want to know sooner than if my husband was sleeping next to me, because he's usually the one that hears it before I do anyway. So I
got hit in the shoulder last night. Don't you hear that? And I'm like, no, because I'm sleeping. Right. She's like, it's beeping. And I was like, all right.
But for those living alone, I think some strategies, again, this would be a staying safe by being potentially a little bit higher is actually better. So if you know that you are just like done and you are out and you are going to go to bed and you may not be up for the next 10, 12 hours, just set a temp basal decrease. Or again, if you're going to bed at night and you know that wake up in the morning at 6 o'clock is probably not going to be until 10 o'clock because how horrible you feel, maybe you take your basal insulin injection dose down a little bit. I mean, there's safety things. Yeah, you may wake up higher than you want to be, but it's in this scenario of being alone, that would be the safer case. I mean, I'm not advocating, obviously, for waking up at 200 or 300 or whatever.
Every
but
day,
if you wake up at 180 instead of waking up at 100, you know what?
Let it
At
go.
least it was safe.
Well,
So,
I mean, the idea is to get through this unconscious time period and back to conscious safely.
correct.
That's what you're shooting for.
The other component too could be, setting alarms on your phone or setting an alarm clock in that time period just to wait. I mean, as much as you want to sleep and need the rest because you don't feel good, if you really are worried because you already took your basal insulin and you can't adjust it now, or you're getting to that point of just needing to lay down and you just had a meal and you're not quite sure what that bolus is going to do for you, set an alarm.
Right. Yeah.
I mean,
everybody should have an old $8 wind-up alarm clock they can pull out of a drawer and set across the room so that you can't just reach over and touch snooze on your phone and get out of it that quickly. Okay, well, that's really, I think we're finding a lot of good ideas here. So real quick, medications around illness, cough medicine, they make some without sugar, I guess, or I could bolus for it.
They do. It's called diabetic tussin.
Diabetic tussin?
That's what it's called.
They should have called. They really should have just called it Diatussin. But all right, I mean, I'm not in the PR department over there.
It's cough syrup that doesn't have any sugar added to it whatsoever. Does the same job, but doesn't have any, glucose raising component to it. So.
Chris Rock in his stand up was like, rub some tussin on it. Was that my mom used to say? Rub some. Was that who?
I don't remember.
I can't think of. I'll figure that out. Okay, so diabetic tussin.
Yes.
What about, steroids? Steroids are going to push my blood sugar up the entire time they're in the body, right?
Correct. Yes. And the increase can be considerable depending on the dose. So injected steroids, like a cortisone injection into a joint or something like that, those will cause considerable increase in blood sugar. Definitely within the 12 hours after, you're going to need an increase at least 50%. Many times people see 100% increase. And then that increase will last for a couple of days until the dose from an injection sort of starts to dissipate. I mean, the impact of it stays within the body, but the impact of the actual, let's call it, cortisone or whatever else has been injected, whether kind of prednisone or whatever it might be, it's going to dissipate enough that you're going to see the need for that increase in basal dose come back down. It's not odd to see 100% more, 150% more basal dose, especially. Many people who are also paying close enough attention will often also need an adjustment down in their insulin to carb ratios, their correction factors.
Okay.
As far as oral steroids, depending on the dose, and again, on a potential hard stop or a taper of the dose, most often those are for people who have like a bronchial illness and they have like a background like asthma or some other type of lung condition that the doctor really wants to attack the illness to prevent pneumonia or something else, progressing. Those types will usually, again, increase the need significantly, and the insulin to carb and the sensitivity factor will need to be adjusted.
Yeah. Okay. And I guess two medications that may have a side effect of nausea, you should be careful about. If they want you to take them with food, give yourself a chance to not show up, not make yourself nauseous when you might need to hold something down. I want to double back a second to the idea of an alone adult or even a kid whose parents, might feel like it's slipping away. Like, when do it's so funny to ask this question because we spent some time talking about the fact that hospitals don't seem to particularly, value like your blood sugar that much, but when's the moment when you wave the white flag and go to the hospital? Like when am I not that you should be running every time you're sick. And by the way, I feel terrible because some people get sick more frequently than others. I can count on two hands the times both of my children have been ill. Arden doesn't get sick much at all, which by the way, too, for those of you who do, what a horrible joke that is from nature, right? Your immune system was strong enough to beat the crap out of your pancreas, can't make bronchitis go away.
Right.
You're like, whoa, come on, man. But so when do I, what's the Mendoza line for when I think I better get to professional help? And why do I want to do that? What is it I'm avoiding?
that kind of comes in, and I know we had a whole discussion, an episode all about ketones and how to look at that and whatnot, but that kind of brings that into the picture as far as blood sugars and or hydration. And if you are ill and you're really not feeling good, check ketones, because in the case of moderate to high ketones, those often, especially if you are not feeling well and you can't get enough hydration and fluids in, you may very well need to go to the emergency room. In that case, it's just, and your blood sugars may not look like high enough to say, well, gosh, this is really bad. I have to go to the emergency room or the hospital. But if your ketones are at that moderate to high level, you definitely need some help clearing those, or you're going to be in trouble.
And an IV would help with that, right?
An IV would help with that because they're not going to make you down a whole bucket of water via your mouth.
Because
they're going to put an IV in, and they're going to push it in through your vein.
Because if you could, you would too. And I know I know that because, and I think I've told this here before, but Arden woke up one time with she had a bent cannula, one bent cannula in like 14 years. Is amazing. But she woke up.
That is pretty amazing.
Yeah, she woke up with a higher blood sugar. She was nauseous. I tested her ketones; they were high. And I said to her, "I'm like, look, here's your options." Now she wasn't sick, like she didn't have a stomach virus. I said, "You pound this water down. I crush you with insulin, and you promise me that you can eat something to stop the fall, right? Or we're going to the hospital." And she's like, and she took a bottle of water from me. And Arden is, and I've mentioned this here before, she's a princess sipper when she drinks water. It's like, a little bit. She took that bottle of water and she pounded it all down. And she was like, "Is that good?" And I went, "Yeah, you can sip at the next one." And we got like 3 bottles of water in her over 2 hours. We made a big bolus. Her blood sugar broke and her ketones began to fall, and we caught it with with something, and that was it. It took us 3 hours to not go to the hospital, but she was willing to do it, and it was hard. She told me later that drinking that water was incredibly difficult because of the pain she had from the elevated ketones. She felt very nauseous from it. Obviously she wasn't sick, but at some point there's going to be a safety issue. Please don't get to the point where you're calling an ambulance. You know what I mean? Like you might have to give up at some point.
Right.
You're doing
and
all
this kind of brings into a component of like nausea in pregnancy can be a very considerable thing for some women, especially in early pregnancy. Okay. So if you have significant enough nausea and you're not literally able to take things in, or you have gotten to the point of actually vomiting because of the significant nausea, it's always better to try to go and get at least IV hydration so that you don't run into an issue of ketones. Even though blood sugar levels may not be elevated in that circumstance, you could develop ketones mainly because you're just not keeping anything in. And that's very, very, very bad in pregnancy.
Can I ask you a question? And I don't usually put you on the spot for this because it's a question about how to do the podcast. When I put this episode out, I was thinking to put the defining ketones right with it. Do you see them as these are companions to each other? Okay.
Absolutely. All right. That's a great idea.
I will definitely do that then. This is usually the time where I say, is there anything I didn't say that I should have said?
The only thing I would say is for all of this, the biggest thing comes from like my years with Girl Scouts. Be prepared.
Okay.
Right? Be prepared. And one of the best things I can recommend doing is you never know when you're going to have to run out the door to like an emergency like situation, right? Or even in the case of, I know this isn't illness specific, but this is like just being prepared. Like you have to run out of the house because, I don't know, your stove is on fire or something, right? I mean, if you have a diabetes emergency bag packed, get a backpack, a red backpack, cheap, go to Target or wherever, get one, put in it all of the things you could potentially have to take with you quickly out of the house. it'll be a lot easier in an illness emergency, especially if somebody has to take you out of the house.
Right.
If you got stuff packed to go, at least you've got, a set change and extra test strips and batteries and whatever, they're all in there.
Yeah. No, so a Jumanji situation when giant vines and lions are going through your living room and you really need to get out, you want to be able to grab this bag.
Correct.
And at least have it packed somewhere and it doesn't have to be hanging by the back door.
When the monkeys are chasing you through the kitchen
Those
and
monkeys
whatever.
were very mean in that movie.
They were. They were horribly mean. I know.
Or Robin Williams. And now people are like, Robin Williams wasn't in that movie. That was The Rock. How did you confuse those things? And who is Robin Williams? But there's been 2 Jumanji movies. So young people, please leave me alone. I want to close by saying that as we were talking, I was proudly struck by how much of what is normally spoken about on the podcast translates very well to this idea of sick days. That, obviously there's heightened scenarios, but that the tools you use really aren't much different. You might use different ones in different times than normal, but it's not like, and the reason I say this is because when people are trying to figure things like this out, I oftentimes see them believing that there's some extra special knowledge that they don't have about diabetes that applies only to the day you're sick. And I still think that one of your greatest diabetes tools is common sense. And so I think that, we obviously broke things down a lot more granularly here, but it's still the tools. It's the Pro Tip series, applied slightly differently. So I thought this was really terrific. Awesome. I appreciate you doing this. And we talked so long that I can't ask you to define LADA. So I'll do that next time.
Okay.
So that you can go. I will say thank you.
You're welcome.
I want to thank Ascensia Diabetes for sponsoring the Remastered Diabetes Pro Tip series. Don't forget, you can get a free Contour Next Gen Starter Kit at contournext.com/Juicebox free meter. While supplies last, U.S. residents only. If you're enjoying the remastered episodes of the Diabetes Pro Tip series from the Juicebox Podcast, you have Touched by Type 1 to thank. TouchedByType1.org is a proud sponsor of the remastering of the Diabetes Pro Tip series. Learn more about them at touchedbytype1.org. A huge thank you to one of today's sponsors, Gvoke Glucagon. Find out more about Gvoke HypoPen at gvokeglucagon.com/juicebox. You spell that GVOKEGLUCAGON.com/juicebox. If you're living with diabetes or are the caregiver of someone who is, and you're looking for an online community of supportive people who understand, check out the Juicebox Podcast private Facebook group, Juicebox Podcast Type 1 Diabetes. There are over 41,000 active members, and we add 300 new members every week. There is a conversation happening right now that would interest you, inform you, or give you the opportunity to share something that you've learned. Juicebox Podcast, Type 1 Diabetes on Facebook. And it's not just for Type 1s. Any kind of diabetes, any way you're connected to it, you are invited to join this absolutely free and welcoming community. I hope you enjoyed this episode. Now, listen, there's 26 episodes in this series. You might not know what each of them are. I'm going to tell you now. Episode 1000 is called Newly Diagnosed or Starting Over. Episode 1001, all about MDI. 1002, all about insulin. 1003 is called Pre-Bolus. Episode 1004, Temp Basal. 1005, Insulin Pumping. 1006, Mastering a CGM. 1007, Bump and Nudge. 1008, The Perfect Bolus. 1009, Variables. 1010, Setting Basal Insulin. 1011, Exercise. 1012, Fat and Protein. 1013, Insulin Injury and Surgery. 1014, Glucagon and Low BGs. In episode 1015, Jenny and I talk about emergency room protocols. In 1016, Long-Term Health. 1017, Bump and Nudge Part 2. In episode 1018, Pregnancy. 1019, Explaining Type 1. 1020 glycemic index and load, 1021 postpartum, 1022 weight loss, 1023 honeymoon, 1024 female hormones, and in episode 1025, we talk about transitioning from MDI to pumping. Before I go, I'd like to share 2 reviews with you of the Diabetes Pro Tip series, one from an adult and one from a caregiver. I learned so much from the Pro Tip series when our son was diagnosed last summer. It really helped get me through those first few very tough weeks. It wasn't just your explanations of how it all works, which were way better than anything our diabetes educator told us, but something about the way you and Jenny presented everything, even the scary stuff, that reassured me that we could figure out how to deal with this and to teach our son how to deal with it too. Thank you for sharing your knowledge and experience with us. This podcast is a game changer. 25 years as a type 1 diabetic, and only now am I learning some of the basics. Scott brings useful information and presents it in digestible ways. Learning that pre-bolus doesn't just mean bolus before you eat, but means timing your insulin so that it is active as the carbs become active, took me already from a decent 6.5 A1C down to a 5.6 in the past 8 months. I've never met Scott, but after listening to hundreds of episodes and joining him in his Facebook group, I consider him a friend. Listening to this podcast and applying it has been the best thing I have done for my health since diagnosis. I genuinely hope that the Diabetes Pro Tip series is valuable for you and your family. If it is, find me in the private Facebook group and say hello. If you're enjoying the Juicebox Podcast, please share it with a friend, a neighbor, your physician, or someone else who you know that might also benefit from the podcast. Thank you so much for listening. I'll be back very soon with another episode of the Juicebox Podcast. Jenny Smith holds a bachelor's degree in human nutrition and biology from the University of Wisconsin. She is a registered and licensed dietitian, a certified diabetes educator, and a certified trainer on most makes and models of insulin pumps and continuous glucose monitoring systems. She's also had type 1 diabetes for over 35 years, and she works at integrateddiabetes.com. If you're interested in hiring Jenny, you can learn more about her at that link.